There's something happening also psychologically. And what's really interesting, if you go back through the history of perinatal mental health, there's been evidence from the first publications in literature mentioning something happening to women during the perinatal period in terms of their mental health. However, it was something that wasn't, I suppose, developed. It wasn't something that was investigated further. And there may be many, many reasons for that. I guess you all know who this is. You haven't seen him recently. If you're ever doing research, remember this quote. So this is Hippocrates, who's known as the father of modern medicine. So every doctor that qualifies takes the Hippocratic oath. Did you know that? So this is Hippocrates, who would be the first writer in terms of modern health and literature, okay? And this is his proposal. He said that there was something happening to women during the after birth, and he proposed that it was local discharge, if suppressed, could flow to the head and result in agitation, delirium, and attacks of mania. So that is the first hypothesis as to what was causing agitation. So he was obviously in the 4th century seeing agitation, delirium, and mania in women post-birth. So this whole area is not something new. However, what's really interesting is that I'll stand over the research that I've done now, but when somebody looks at it in 1,000 years' time, they may have, the whole body of evidence may have evolved. And that's why we always have to be open to new research, to new evidence. When I started talking about paternal perinatal mental health, I met a lot of resistance from clinicians. I met a lot of resistance from colleagues in academia as well, in terms of, is this something that's real? Are you sure this can happen? So if Hippocrates can have a hypothesis like that, well, surely be to God, I can put forward my research as the latest evidence. Okay, so this is one theory in the 14th century. Historically, in terms of medicine, women wouldn't have had the same role as men. It was how society worked. However, Trotula, who would be a famous 13th century female physician, also believed that she saw disturbances in women. So her hypothesis in the 13th century was that if the womb is too moist, the brain is filled with water, and the moisture running over the eyes compels involuntary shedding of tears. Okay? We're moving closer to the truth, but we have a long way to go. And that's what I always say to the students that I have. I'm teaching you what I know best for now. However, the evidence may change, and what I say today may not be the best practice or the best evidence tomorrow. Okay, you must remember you have to always put somebody's situation in the context as to where the times that they live in. And I'm very conscious of this when I talk about men, their mental health, and their mental health during the perinatal period. So there are certain expectations, and there are certain results of those expectations. So during the Middle Ages, if you did exhibit signs of melancholy, you would be at risk of being called a witch, burnt at the stake, institutionalized, whatever it may be. So there was high risks, and those risks did not go away in the 14th, the 15th, the 16th, the 17th, the 18th century. In the 20th century, in Ireland, there were people had one episode of mania and they were locked up for the rest of their lives. There was and there is a lot of stigma around mental health in general and also in the perinatal period. 16th century, another example. Again, similar, and this time it says that the insanity remained for a month, but then recovered with treatment. We're not sure what treatment it was. However, that's what is wrote at the time. Would that be nice to know? But maybe that was what we call the baby blues. Do we call that today? You know the term? Maybe it was something like that. We don't know, but that was certainly said. Then we're moving towards the 19th century, and Marseille, he published the first formal paper devoted to perinatal health. The name was a little bit insensitive, one would have to say, Insanity in Pregnancy, Postpartum and Lactating Women. However, it was the first time that there was a specific focus on research related to perinatal period. Have you heard of the Marseille Society? So the Marseille Society is still there today, and it's a body that looks at perinatal mental health. And we also look at paternal perinatal mental health as well. So what he wrote was that he had 310 cases of pregnancy, and what he observed is that some women became unwell, and he reported 9% during pregnancy, 58% during the first 6 weeks. And then when he talks about the lactation period, you'd imagine that might have been up to 6 months, 33%. Okay. Again, we don't know what kind of diagnosis he was using, what tools he was using. And what you'll see from the research is that the prevalence of something that you get may depend on the tool that you use. So we don't have a lot of information, but these are the stats of prevalence that are available in terms of that particular study. And the Marseille Society, today's group of researchers who unite to look at perinatal mental health. Okay, so basically there was 20th century, two bodies of literature, two different theories. One put forward is that there's no relationship between pregnancy and delivery. Our postpartum changes were indistinctive from other psychiatric illnesses. And I would say that things are changing. However, that would have been very prevalent, that theory, up to maybe 30 years ago. However, things are starting to change, and maybe we will look back in time and we'll say in relation to paternal perinatal mental health, there was two theories in the 21st century. One was that there was nothing and fatherhood didn't impact. However, others suggest that there is a link, an association between physiological changes and mental health outcomes during the perinatal period. Very much so during this period, it was all focused on the physical. And if you look at the body of research in perinatal mental health, up until, let's say, 1990 and beyond 2000, a lot of the research with women only focused on depression and only focused on the postnatal period. If you said to somebody, tell me something about women's mental health during the perinatal period, the majority of people would say, oh, postnatal depression. Am I right? The evidence would suggest that anxiety is more prevalent, and there's issues around stress as well. Yet the first studies and the first screening tools that were used were related to depression, and therefore a lot of the research initially, because now we had a screening tool, we can do research, looked at depression. Okay. So we start to move into the 20th century, and you can see that psychiatrists started looking at mental health. You know, and remember, as I said, the social context, women didn't seek help because they were worried that they would be put into mental institutions. And if you went in there, there was a possibility you weren't returning. And if you went in there, there was a possibility that your child was taken off you. We have failed women terribly in the healthcare system, in the health service, and we have failed other populations as well. But when you think of what we did and why we did it, you know, we've got to learn from that. Thankfully, we are more scientific based, more evidence based. We have more evidence to pull from. In Ireland now, it's time to wake up. In Ireland now, we have moved from institutions for mental health, moving people out into the community. Integration. It's now about recovery. This is a new field in mental health in general, in terms of recovery, moving people out, trying to get people integrated back into society, into what they're doing. The 2006 policy for mental health in Ireland is called A Vision for Change. And that policy, the core element of that policy was to move people from institutions out into the community. A fantastic idea. However, they closed down the institutions. They moved people out into the community. They didn't support them. And people who had been institutionalized for 30 years certainly didn't know how to live alone out in the community. They were lost. They didn't know what to do. And they ran into subsequent new problems. That model was very laudable in terms of what it set out to do. However, the systems were not in place to deliver it. We have a new policy that has the same goal in terms of community, but different support networks now to integrate in a more communal way, but within communities. Again, we move into the first talk of an atypical depression in 1968. This was in response to getting feedback from health visitors who said they noticed changes in women during this particular period. So if you want to be, there's two things happening in terms of perinatal mental health that I'm very conscious of. Number one, we've got to be aware of the evidence. Is something happening? Because if something's happening and we're not doing something about it, we're failing to support people. However, we don't want to make it a situation where we're medicalizing childbirth, where we're medicalizing motherhood, where we're medicalizing fatherhood. So it's a balance between trying to support and to have the services in situ, while also understanding that a lot of these changes, the stress, the anxiety, the hormonal changes related to depression and social circumstances are transient. And with adequate supports, people can be helped and we don't run into issues in terms of extended depression, stress and anxiety. So if we see, we started in the 4th century, it wasn't until the 1990s that formally that a diagnosis for postnatal depression came in the DMSI. And if you know the DMSI is the Bible of psychiatry. If it's not in there, it doesn't exist. So the reality is that fathers' mental health problems don't exist because it ain't in here. But what's really interesting is that is only 30 years ago. That's not long ago. So if you went to see a psychiatrist and it was related to, you know, the perinatal period and postnatal depression, no, I don't know. This is really used for clinical diagnosing. However, when the definition did come, it didn't correlate with the epidemiological evidence. What the actual DMSI states is that it is within, initially it stated that it was in the first 4 weeks of pregnancy. However, the evidence was saying that it can happen in the antenatal period, and it certainly can extend out to a year, if not beyond to 2 years. The research is changing, but certainly up to the first year, we would consider to be a period where symptoms can develop. The DMSI, the 5th edition came out in 2013, and now it does state up to the first year of postpartum. Okay. Again, one of the big changes was to have a screening tool. And the most famous screening tool that we use is the Edinburgh Postnatal Depression Scale. So that's widely used to screen for depression in postnatal women. That is the tool that we have been using for men to screen for postnatal depression. But if you look at the symptoms on this screen, well, it's not the screen, on the actual, the questions that you ask in the Edinburgh Postnatal Depression Scale, and if you look at the manifestations of depression in men, they're two completely different things. This talks about crying. Men don't cry. Men go out and break things, including themselves. Men don't internalize their anxiety, their depression. Men externalize it. Alcohol, smoking, risky sex, gambling, working. None of that's in here. This is about internalizing. However, we have a developed tool that seems to pick up postnatal depression symptoms in women. However, we have 10 questions, 30 to 0. Is it 30 to 0, 30 to 10? I can't remember, but you can get up to 30. I can't remember what you can start it, but you come to a cutoff point where if you score beyond this, you're at risk of. That cutoff score can be elevated, it can be decreased, and depending on where you put it, can depend on whether somebody screens positive or not. So we have to have, you know, validity and reliability in terms of the tools that we're using for the populations that we're using. For example, if you look at the questions there, you can't have the same cutoff score for men as for women because you're looking at two very, very different sets of populations. Another issue in terms of the Edinburgh Postnatal Depression Scale is I've sat and somebody has screened somebody and they said you've postnatal depression. After doing that, that is not a diagnosis for postnatal depression. That is, every screening tool that you use is not a diagnosis. It's for screening. It's to look at risk. In order to have a diagnosis of depression, you need to be referred on and you need to have a psychological assessment to see, do you have a diagnosis? So even a lot of the research that I've read, and I still read today, I would say the 90% of the research that I read around paternal perinatal mental health talk about a prevalence of depression of X, Y, and Z. It's not a prevalence of depression at all that they're talking about. It's symptoms of depression on a screening tool. They're two completely different things. And that's important for practitioners to remember and for researchers to remember that it's not a diagnosis. It's a risk of in terms of a screening tool. So over the past 40 years, there's been a lot of questions like, is pregnancy a risk factor for depression? Or is it a protective factor for depression? And are there other things besides physical symptoms that can impact on somebody's mental health during the perinatal period? So these are some of the questions that have been asked, and The program that I run and that I manage, I think it's really good to look at, instead of just constantly looking at risk factors, you're at risk of this, you're at risk of that, you're at risk of the other. What about what protects you from this? What protects you from what protects you from anxiety? What does the evidence say is protective against anxiety for college students? Does the evidence say is protective for anxiety for fathers, for sports athletes, whatever population you're looking at? It's important to look at the protective factors. How can we support this population by looking at what protects them? Yes, we've got to know what risks are there, but we need to also look at protective factors, and public health nursing that I do is all about prevention, promotion. Yes, we look at secondary issues, however, it's about prevention and promotion. So men start to sneak in a little bit here, because when you ask the question, are there any other things that might affect mental health during the perinatal period, and you find out that there's, an unwanted pregnancy, there's sleep disturbance, there's relationship strain, there's financial, well, that's financial, it's spelled wrong, financial strains. So fathers can experience these things, so perhaps they can experience adverse outcomes during the perinatal period. However, we don't know because we didn't look at it. But it certainly raised questions. If this can impact women, can impact men as well. So when the debate moved away from the physical symptoms and begun to look at the social aspect and the relationship aspect and the environmental aspect, then we can start to say perhaps this will impact on fathers as well. Okay.